Okay, good morning, good afternoon, and good evening, everyone. Thank you so much for joining us today to our webinar titled Knowledge, Beliefs, Attitudes, and Self-Efficacy, Strengthening an Individual's Ability to Achieve Their Reproductive Intentions. My name, next slide, please. My name is Maria Carrasco, and I'll be moderating today's webinar. I am a behavioral scientist, and I currently work as a Senior Implementation Sciences Technical Advisor for the Office of Population and Reproductive Health at USAID. In this role, I coordinate work on the high impact practices in family planning, or HIPS. And I work closely with a HIP technical advisor group to develop guidance, to develop the 3 SBC HIP briefs. And one of them, you will hear about one of those briefs today. And I have to say that for this particular brief that we're presenting today, I worked with others to review the literature, and it was a big task. There's actually quite a number of articles, a lot of articles on this topic of knowledge, attitudes, beliefs, and self-efficacy on these 3 topics. It was a wonderful experience to collaborate with a very talented group of colleagues to bring you the brief that we are presenting today, and also to bring you today's webinar. Next slide, please. Thank you. I'll be giving you, here's the agenda for today. I'll be giving you a brief summary of what the HIPs are, and then my colleagues Joanna Skinner will present a summary of the SBC overview brief, which is another brief that we have prepared for you and is important to highlight and for you to be aware of. And then my colleagues Lynn Van Leith and Larvaid Abid will present the knowledge, attitudes, beliefs, and self-efficacy brief, and they'll also share an example from experience. And we will leave approximately 20 to 15 minutes for questions and answers. So please write down your questions and have them ready. And also don't forget to keep adding them to the questions section of this webinar platform. Next slide, please. Now, before we begin, next slide before we begin. That's great, thank you. Now, let's go through some logistical information. And as I was noting, if you have any questions, please note them on the questions portion that is on the right-hand side of your screen. Please note that this webinar will be recorded and that we will post it on the HIPS website in due course, most likely very soon after we finish the webinar today. If you find this webinar helpful, please share it with colleagues, and feel free to download all of the handouts for today's webinar from the HIPS website, and also you can go to the command channel on this webinar platform and find the handouts there. So again, keep your questions and write them in the question section, and let's get started with some of the content today. So on to the next slide, please. Okay, so what are the HIPs? To begin, let's discuss what are the high impact practices in family planning. They are briefs that in 8 short pages encapsulate or summarize what works in family planning. The HIPs are practices vetted by a group of experts against a specific criteria. And this criteria includes replicability, scalability, sustainability, cost effectiveness, and evidence of impact in achieving various family planning outcomes. And a critical characteristic of the HIPs is that they are short and written using very clear language. And they are written for an audience that doesn't necessarily have to be an expert on the topic in the brief. Next slide, please. Okay, so in terms of the HIP categories, there are 4 categories that you see here on this slide. They are enabling environment, service delivery, social and behavior change, and enhancements. The knowledge, beliefs, attitudes, and self-efficacy brief that we're discussing today is one of 6 SBC or social and behavior change briefs. So let's talk a little bit about social and behavior change for those who are not very familiar. SBC with this topic. SBC is an evidence-driven approach to improve and sustain changes in behaviors leading to improved health outcomes. And SBC programs employ a deep understanding of human behavior that draws from a variety of fields, including communication, social psychology, anthropology, behavioral economics, sociology, human-centered science, social marketing. Please note that it's not just communication. We have advanced, or if you will, or progress in this field of SBC to include considerations from all of these other areas. In recent years, SBC programming for improved health has gained a lot of traction and momentum. In fact, very recently, the WHO issued a resolution supporting the use of behavioral sciences for better health. So again, highlighting the importance of SBC programs to achieve health outcomes. The need to ensure health programs include SBC components, in fact, has become very critical. And in fact, I think the testament of all of you attending today's webinar is a testament to this, to the importance of SBC and importance of health practitioners understanding what SBC programs are all about. So in today's webinar, for those of you new to SBC interventions, we hope that you learn a little bit about SBC and of this topic we're covering today on knowledge, beliefs, attitudes, and self-efficacy. And for those of you who are experts in this topic, we hope that the example today gives you some new ideas on how to implement SBC programs that advance knowledge, beliefs, attitudes, and self-efficacy. Next slide, please. In this slide, you have the list of all of our high impact practices briefs, and I encourage you to go to our website to download any of these very helpful tools. Next slide, please. Okay, so before we start and I introduce our first panelist, I want to thank very briefly the authors for the brief that we're presenting today. You'll find all of the names at the end of the brief. They worked for many, many months, over 12 months, to bring this document to you. Again, we hope it's very helpful in your work. And I also want to thank the family planning experts who provided comments during the public commenting period and the technical advisory group who reviews and vets the briefs that we offer to all the family planning community. Next slide, please. So we are going to start and on to the next slide with our first panelist. So today we have three panelists, as you saw in the previous slide, Joanna Skinner, Lynn Van Leed, and Lara Abid. We are starting with Joanna. Joanna has over 20 years of experience working in social and behavior change programs, and she currently works at the Johns Hopkins Center for Communication Programs. She has managed social and behavior change programs in numerous countries and has expertise across health areas, including family planning, reproductive health, maternal and child health, HIV/AIDS, malaria. And Joanna is the lead author of the SBC overview brief that she is about to present. So with that introduction, over to you, Joanna. Thank you for being here today.
Thank you, Maria, and good morning, good afternoon, good evening, everyone. So before we get into the details of the knowledge, belief, attitudes, and self-efficacy brief today, we're going to spend a few minutes to get a shared understanding of SBC and how the different SBC HIP briefs fit together. Next slide, please. So Maria already gave a quick overview of our definition of SBC, so I won't go into this too much, but just to reinforce that SBC is an evidence-driven approach that really works across this systematic process to design and implement interventions at the individual, community, and societal levels, as shown here in the social ecological model. Next slide, please. So evidence shows that SBC interventions are an essential component of high-quality family planning programs, but remain underutilized. Investments in SBC interventions enhance those made in the other HIPs in service delivery and policy and the enabling environment that Maria just shared, and can be highly cost-effective. The SBC HIPs include 6 briefs that document proven and promising practices to help individuals and couples achieve their reproductive intentions and desired family size. These include 3 existing briefs that help to identify a mix of channels to reach your audience, namely mass media, community group engagement, and digital health for SBC, and you can see those over on the right of this diagram. While these briefs outline the evidence for each specific channel, SBC programs are most effective when they use a multi-channel approach, and there is consistent evidence that shows the greater exposure to SBC campaigns through different channels, the greater the odds of behavior change, which is known as a dose-response relationship. And so it's really important to think about how we can use these briefs and these high-impact practices together. 3 new briefs have now been added to the SBC suite, including the one we'll dive into today, that explain how to understand and address different determinants of family planning behavior, which you can see on the left, nested in the social ecological model. An important note for today's discussion is that while individual level approaches are necessary and important, SBC programs need to also consider and address the interpersonal, community, and social levels to truly see a difference in behavioral outcomes for family planning. And so our intention is really that these are used as a suite and used together. Next slide, please. In addition to introducing the 6 briefs and how they relate to each other, as well as the other HIP briefs, the SBC overview brief provides some overarching tips for implementation. First, using formative research based on theoretical models to guide which determinants to address. To ensure early and frequent pre-testing of materials, messages, and approaches, which ensure programs are designed with the full input of the intended audience and their influences. Selecting channels to meet the target audience and objectives based on formative research, and working with existing community groups and communication platforms. Next slide, please. Segmenting audiences into subgroups based on demographic, psychographic, life stage, and behavioral factors, and tailor those interventions accordingly. Intentionally incorporate equity and the social determinants of health into SBC programs for family planning. Use a gender-synchronized approach in SBC programs for family planning. And design and use monitoring and evaluation methodologies to assess the impact of interventions and make real-time adjustments to programming. And each HIP brief also gives some specific tips for implementation relevant to those specific areas. Next slide, please. Lastly, there are a number of general SBC tools included in the overview brief, a few of which are shown here, including the business case for investing in social and behavior change for family planning, which uses an evidence-based approach to answer questions about the effectiveness, cost-effectiveness, and return on investment of SBC and family planning. The behavioral drivers model, which is used as a basis to conduct situational assessments and design strategies and programs. The Compass for SBC, which is a curated collection of SBC resources and offers the highest quality how-to tools and packages of materials for SBC. And Behavior Change Impact, which is a collection of databases, as well as reports, briefs, fact sheets, and infographics to provide the evidence that stakeholders need to make the case for the value of SBC and strengthen the impact of their SBC efforts. So I encourage you to review the SBC overview brief. And with that, we'll move us over to Lynn to dive into the focus brief for today. Thank you.
Thank you very much, Joanna. So just before we go to Lynn, very briefly, I want to introduce her. It is my pleasure to introduce Lynn Van Leet. She has nearly 30 years of experience implementing social and behavior change programs, and she has a deep expertise implementing programs in various low and middle income countries. Her technical work has concentrated on adolescent girls and young women, reaching men, community engagement, and engaging healthcare providers. And she currently serves as the technical director for Breakthrough Action. So with that very brief introduction, over to you, Lynn, and thank you so much for being here with us today.
Thanks so much, Maria. And as Maria mentioned, I am one of many people who worked on this brief. So I really want to acknowledge everyone else who was involved. And also mention that we had held a similar session at the SBCC Summit in Morocco this past December to try to really get these briefs out there and make sure that people are aware of them and are using them. So this is a wonderful opportunity to continue sharing these briefs. So next slide, please. Great. So let me just start with a brief background. And again, you know, this brief, I think, is foundational to any SBC programming. And we know plenty, there's tons of research out there that notes that individuals with accurate knowledge, beyond knowing just contraceptive methods, but knowledge of fertility, of contraceptive side effects, that all of those pieces of information support women's use of contraceptive methods as well as men's. So for women to really fulfill their fertility intentions, it's essential that they have accurate information. And we also know that other factors influence someone's ability to reach those fertility intentions, including beliefs, attitudes, and self-efficacies. And Joanna mentioned there are several theories that highlight these factors in social and behavior change, including the theory of planned behavior, social learning theory, and the ideation theory. And there are certainly many others. So if we move to the next slide, just want to share briefly, to highlight the connections between knowledge, beliefs, attitudes, and self-efficacy. They're very closely related and absolutely influence each other. For example, misconceptions around contraception often are a function of poor or inaccurate knowledge. And in some settings, these misconceptions may really impede use of family planning. They also can affect not only non-use, but discontinuation of contraceptive methods. And finally, calling out self-efficacy is a really powerful form of belief. That is the belief in one's own ability to practice a behavior, and is certainly recognized as a key influence on family planning use. So moving to the next slide, why is this practice important? I mentioned, of course, it's foundational to any social and behavior change intervention, but there's plenty of evidence that shows that strengthening family planning knowledge is absolutely essential, and that individuals who have correct information about contraception, including side effects, tend to look more favorably upon and are more likely to use family planning. There's a study from low and middle income countries focused on adolescents that directly showed that low levels of sexual and reproductive health knowledge are associated with reduced access to contraception, particularly among unmarried adolescents. And that's one of many studies that highlight this reality. Holding misconceptions is also a strong predictor of non-use of contraceptive methods, and has been noted again and again as a barrier to use across several countries. Favorable attitudes about family planning, on the other side, really influence voluntary and consistent contraceptive uptake. We know that supportive attitudes, not only by the individual, but also by religious leaders, men, mothers-in-law, all of these other influencers are certainly related to contraceptive uptake and family planning among women. And a few weeks ago, there was another webinar highlighting the brief that Joanna mentioned on couple communication. So I highly recommend that you go to the website and see that as well if you haven't already. We know that favorable attitudes, influence voluntary and consistent contraceptive uptake, as I mentioned, and that self-efficacy is strongly associated with voluntary contraceptive use. For example, there was a qualitative study in Mozambique that found fostering individual-level protective factors such as hope and self-efficacy among young women can help prevent pregnancy and child marriage. Let's move to the next slide and quickly glance at the theory of change. As you can see from this, if you move from left to the right, you'll see some of the barriers noted in the literature, the high impact practice, of course, that we're talking about today, looking at interventions that strengthen knowledge, attitudes, beliefs, and self-efficacy, and the changes that we hope to see, as well as the behavioral outcomes and ultimately the impact, which include fewer unintended pregnancies, fertility intentions that are achieved, that is whether someone wants to practice family planning or not, have a child or not, and that gender equality is improved. All really important impacts that we're trying to see, and that the evidence show will work with this high impact brief. So let's move to the next slide and explore what interventions work. As you can see, we have several listed here, and there is a great deal of evidence around what is most effective. And we know that working across the socioecological level, not only at the individual level, but these other levels around couple communication, community level engagement, service delivery environment, and the overall supportive environment are essential. So there's a great deal of evidence around the impact of mass media. One systematic review in particular found that 8 of 9 family planning mass media studies, that in those studies, exposure to mass media was associated with higher levels of knowledge and/or positive attitudes around contraception. We also know, and this was mentioned before, that multi-level interventions are incredibly effective, that addressing factors across those different socioeconomic or socioecological levels are important. We know that individual and couples family planning counseling is incredibly important, and that counseling is most successful when it addresses an individual client's preferences and needs. Community group engagement and participatory discussions or workshops have also proven to be incredibly effective. And those participatory methods in particular with small group discussions and role plays have been proven to be effective. And finally, we have digital tools, that there is a great deal of growing impact around interventions that use digital tools to achieve family planning goals, and including activities that address service and contraceptive access barriers. When you go to the brief, and that's shared in the chat, that you'll see lots of evidence, and I call out particular studies from Nigeria, Jordan, Guinea, and Bangladesh in the brief. Moving to the next slide, additional tips for implementation. And Joanna had mentioned the first one, the importance of formative research. I mention it again, and it's highlighted in the brief since it's so incredibly important to make sure that whatever the social and behavior change intervention is, that it is designed for the local context and building on data from that local context, wherever it may be. We know that we need to make sure that messages are meaningful to the audience, and that we consider existing levels of individual knowledge. So in many cases, and many countries, general family planning knowledge is high. However, in some cases, method-specific knowledge can be quite low, whether that's around LARCs or permanent methods. And so sometimes it's really important to focus on increasing method-specific knowledge, beliefs, attitudes, and self-efficacy. And in all messaging, we want to make sure that we're using compelling language delivered by trusted sources for specific audiences. And addressing myths and misconceptions must be done directly but carefully so that those misconceptions are not reinforced. There are also, of course, potential side benefits of contraception worth highlighting, including other health and lifestyle advantages. And that we really need to look at improving self-efficacy for clients to communicate with their providers. So interventions that affect both individual knowledge and what happens when in the counseling experience are incredibly effective, so that clients can ask questions like, how effective is this method? Or, what side effects should I expect? These are all really important considerations. We also want to make sure that we're including men and adolescent boys when we're talking about improving knowledge. That will only help to improve couple communication and shared decision making. So these types of gender synchronized interventions are really important to involve men, boys, women, and girls across the board, so that we're doing so intentionally and mutually reinforcing information and messages as we progress. And finally, the real importance here of paying particular attention to the needs of diverse adolescents. We know that messages and beyond messages, social and behavior change approaches need to be tailored to adolescent-specific life stage and needs. Certainly, early adolescents have very different needs when it comes to information and things of that nature versus older adolescents who are approaching sexual activity. Let's move to the next slide now and look at implementation measurement. There are many indicators, so I want to refer everyone to the SBC indicator bank, but I'll highlight 4 most specifically related to measurement of this particular brief around knowledge, attitudes, beliefs, and self-efficacy, around percent of target audience that knows potential contraceptive side effects, percent of an audience with favorable attitudes of modern family planning methods, percent of the audience with high self-efficacy and that confidence in their ability to use a family planning method, and finally, the percent of the target audience with a high efficacy and confidence in their ability to talk with a provider. Again, really emphasizing the importance of that client-provider interaction. Let's move to the next and final slide, highlighting 3 resources that we called out in this particular brief. The first is around how to design SBCC messages. And this is a really helpful how-to guide. It really provides step-by-step instructions and hints and key resources and references. So please draw your attention to that one. Joanna mentioned the compass, and I want to highlight it again. It's just an incredibly helpful curated collection of SBC resources for any professional to improve their work. It's been updated recently in the past year, so it's very easy to do a search by country, by specific area, by approach. You'll find a lot of information there. And finally, the guidance on social and behavior change for family planning during COVID-19. I think there's a lot of information here that is still relevant, including considerations and additional resources to guide adaptation of SBC programming focused on family planning. And while it was focused and the impetus was to address family planning during COVID-19, there are still many other resources that could be of use to you. So with that, I will thank you very much.
Wonderful. Thank you very much, Lynn. And let's move forward to our last but not least presenter. We are very lucky to have here with us today Larraïv Abid. She is a lecturer, activist, trainer, and entrepreneur, and the founder of Mashal. And she is a focal person on sexual and reproductive health in the Prime Minister National Youth Council, which works on digital rollout sessions and policy making focusing on sexual and reproductive health. Larraïv, because of her work, was recognized as a family planning young leader by the Bill and Melinda Gates Institute. So with that, I'll pass the floor over to you, Larraïv. Thanks.
Hi, thank you so much for a lovely introduction. Hello, everyone. This is me, Larraïv, and it's been amazing listening to Lynn and other presenters because they have been telling how certain strategies worked out. And here I'm going to tell one of the examples that I've been implementing in my country, and that is the implementation perspective. Next. So talking about the context of Pakistan, the problem statement because of which I started working was that Pakistan, is the first one of those countries where we have a lot of population issues in terms of its planning, in terms of its resources, and we have a prominent youth slot. In Pakistan, nobody talks about sexual and reproductive health and rights because a lot of people think it's bad to talk about it and it's unethical. And if you start telling people about it, they'll be more engaged into certain activities that they should not be doing. So when you're talking about it, it's not always easy to, ask people to be on the same page. And then there are some facilities by the state departments, but despite the easily accessible services, people do not go them. There are 2 major reasons, to be honest. One is, lack of awareness, and second are the myths because of which people don't go. And one of the reasons why these services are not able to engage people is the lack of funding in country. And when it comes to the private organizations, there are a lot of problems in terms of registration, in terms of in-country fundings, because of which the people who are not linked to State Department but do have ideas have a lot of hurdles and obstacles to deal with at first. So this is something which is causing, a lot of distress when it comes to family planning and SRHR. But I do believe that even if there are challenges, this is one of those very crucial thematic area that needs focus. Why? Because Pakistan is in economic crisis. There's so many things that has been happening since past 2-3 years, and after COVID, the Department of Health was not even taken as an emergency department. So this is something to really focus on, because whenever floods happen, whenever there was a flood recently, whenever COVID and epidemics or pandemics happen, usually in country people are concerned about food and clothing, but nobody talks about the menstrual cycle, the sanitary napkins, the tampons, the menstrual hygiene and management, because they do not even realize the importance that this is something that you cannot hold, you cannot pause them. So that is a thought process that it doesn't come under the emergency services, because of which the normal campaigns are also not in focus. Next, please. So why I came into this, there's a short story that I want to share with all of you, because that has been my inspiration. So I have been training young men and women since 8 years. I know 8 years sounds a lot, but to be very honest, I was in it when I was a student. And I've been training young men and women, and usually when training used to end, people used to come to me, okay, where we should go? Where are the centers, where is the information? And I used to tell them about the government departments I knew, which were free of cost, maybe one or two or three. So one day what happened, which became my inspiration, was one of my friend who is educated, lives in metropolitan city as an engineer. She asked me to connect to a doctor because there were so many doctors in my family. So I connected her, but I did ask her three questions that, if everything is okay. She said that she doesn't want to have the third child because in Kuwait, there were some issues regarding Pakistani visas. Her husband is there. He comes by annually, but she is not planning to have another kid. So I said, being very curious, and because she was a friend, I said that how come you had no idea about contraceptives after two kids? And she said to me that, if you go before a marriage to a gynecological center in our society, it seems like that there is a problem. There are so many myths attached to it, so you cannot know the contraceptive methods. Just after marriage, there's a joke in country that happens that people are waiting for the good news the very next day of marriage, and they are like, okay, is there a good news? So you don't talk about contraceptive methods for the first years. So she was going with the flow, but now she feels like that the decision was very rushy and she shouldn't have done that because she was not financially, mentally and physically settled. So I said three questions. I said that, we all are having mobile phones all the time. Why you did not Google the information? And she said that, information is scattered. And also, just like Lynn also mentioned, that people sometimes know about contraceptive methods, but what they do not know is about the specific contraceptive method, its usage, what are the benefits, what are the differences. So maybe they just know about condoms in country and they have no idea about the other contraceptive methods. And then she said, the language is difficult, so Google is not an option for me. For the hospital, she already told me that there was a stigma. And third, I said that you could have used telehealth services. And she said, where are the numbers? And to be honest, I also didn't remember the numbers. I also have to look up to the Google. So these all of the things actually gave me food for thought that, okay, I'm training young men and women, that's fine. But can I have something, a tool or anything which I can give after the training? Or maybe tell people about it, how it is important. For me, it was very small thing, and I was just thinking as a tool that I can give after training, or if some of the friends or colleagues or people come to me, there is something that I can say, okay, yes, I have this link, you can share. Because there are a lot of people in our country who say that we do not have sex education in the books at all. There's a lot of generation gap when it comes to parents and children. So I always say that, okay, we have to work for the curriculum as well, but why not when you have this mobile phone along with you all the time for 8 to 9 hours on an average? So why we cannot reach properly to the young people through these gadgets? Why only try for those things which are going to take time? So that's what I thought, and then I did some research, and I realized that there was no single platform, which was talking about all the centers which were free, all the phone numbers, the basic information. I mean, there are a lot of people in Pakistan who just, get, actually majority of them who get sexually active after marriage, and at that point, there's like a peer group, and they do not have authentic sources to tell their friends about that what are the contraceptive methods, what is family planning. And even if you're telling somebody about that, a lot of people also feel like offended that why you're telling them. because they are not comfortable enough. So I just wanted to have something which could be private. Next slide. So what I came up with was, I created a simple mobile application. It was a pilot phase of one city. What I did was that I added simply contraceptive methods for both men and women. I added a manual, which was later on actually collaborated with UNFPA and FPAP. They asked me that they had a LSP manual. It was in English, so we translated that in Urdu as well, because it's the official language, and the contraceptive methods were also translated in Urdu. Then what I did different was I added geotags of all those clinics in my city, which were free of cost, because I started to thought that maybe I should start with some free services, because people say that they don't know about it. Then, of course, it was a time for telehealth services. I added all the phone numbers that I could, and where people could simply just call and they would tell you about the services and the contraceptive methods as well. The next step was to divide the province, because I started with the city and I actually wanted to go to the province categorization. I made province categorization, and then from one city, we expanded to the whole province, and we added 2,500 clinics, which were geofenced, which are still there. Then we also added audio for the people who cannot read and write, and also for the visually impaired people, just to make it as accessible as possible. And then what we did was to make a home delivery component, which includes those things regarding sexual and reproductive health and rights, which can be delivered at home directly. So we collaborated with the store. Next slide, please. So this is like a short sneak peek of the mobile application. Next. This is how it looks like when it comes to mobile application. In the next slide, please. This is the Urdu version. I just wanted to share. It's very simple, very big headings that you can click for HIV here, for contraceptives here, for the clinics here. Next. Then we also worked on the web application, because we didn't want that somebody should be limited to mobile phones. If you're using a laptop, you should be able to access it. Next. And next, and that's the web version of the application. So then what we did was that it was available on Android, it was available on web applications, it was available on website. First I had signups, then I thought that people are not able to, do sign up that quick. So what I did was that I removed the sign up at that time. And the information we have at the back end is the data that we collect with permission, and the data is not specific to location or names or personal information. It's more like the gender or just the general geography from where the young people are reaching out. Next. Next, please. That's the tab version. So why was this application different as compared to the other information which was available? Why this implementation perspective gave me a new food for thought? So maybe you can also think of any application in your country, any application that has three components: information, services, and products. It will be very rare that these three components will be available in one application. It will either be information, it will either be a service or a product. But the combination of these three things actually makes it a full-fledged platform, where if young people are getting married and they need authentic information, they have access to all those things which at least are available. But the bridge is missing, and that is causing further more lack of information and creation of myths. Next. Now, there are a lot of people who would say that, okay, what you would do with the people who do not have, access to the mobile application, and maybe people in the, urban area have access to the information. That's why I always tell this story, that it's a misconception. Even the people around me, the educated ones, the people who have good education living in bigger cities, do not have proper information, and there's a big, huge gap when it comes to family planning, because with the flow, everyone conceives in the first year, and if somebody does not conceive, I mean, I myself I've been married for 3 years, and I know that there's so many people who themselves imagine that there would be some sort of problem going on, that I am not having a child. Nobody would even imagine that it can be because of a method, it can be because of a choice. It's that obvious in my society. So when I realized that 77% of the smartphone users are 21 to 30 years old, because that's the age in Pakistan usually when young people are getting married, I thought that, the target is reachable. It's not like that the target is not reachable. So what we did was, of course, we had the confidence, and we like talking about my whole campaign in the last few years, we reached 3 million young people on all the platforms of like Twitter, Facebook, the social media applications, the mobile applications. We trained 10,000 young persons so far, and then the application got recognized by Punjab Population Innovation Fund, which is a state department, and also a Population Welfare Department, which is also a state department. For us, it was a big deal. We were youth-led organizations. We had no resources, and we started from scratch. And it was very difficult to, have the resources together and pitch it, and even be able to train a lot of people. But when we pitched that, we had a very small grant, which was of a fellowship, because of which we pitched, and it expanded. When we did the training, there were so many women who would come to me and say that thank you, that I'm able to access an information that I cannot even talk about with my parents. There were some people who came to me that I feel embarrassed saying that I had a kid in the first year, but I didn't want him at that time. But now I cannot help it because I cannot reverse that. There were so many people who came to me asking for safe abortion services, because that's a huge stigma in country. So I realized that, okay, so these are the things people cannot talk about publicly because of a lot of comments that they get. So one of the things that happened, and I tried myself that maybe I can use this data. When I got into Prime Minister National Youth Council and we had the policy recommendation sessions, so in the policy recommendations which we made, I tried my level best to increase the budget on family planning and to specifically mention young people in the policies, because when we did the comparative analysis of the policies, it was very clear that the budgetary allotment and the services were not directly targeted. It was a very generic thing, and that's why it was not so effective, although there was nothing on digital platforms as well. And then I also became technical member of Population Welfare Department. And this is a bit sad to say in that way. I became a partner because they had nothing online properly, segregated. So they took us on board to tell them how, they can make the things digitally effective. Again, it was a big, big deal for us because we never knew that just one phone call would turn this idea into such thing where we are collaborating with the state departments and we are literally guiding them how they can use the digital services, because being honest, the people over there lack capacity when it comes to newer platforms, whether it's Instagram, it's TikTok, people are everywhere, and it's a high time that you engage them with like good content, fun content, so that they can learn about it. Now, after this, all that I have been doing in policy and in the community, we also wanted to expand our reach. We made YouTube short dramas, and we actually promoted the mobile application so that maximum people could upload it, download it. But COVID happened, and just before COVID, I was telling everybody how important, it is that we have something online. And at that time, people were like, yeah, maybe, maybe not. And when COVID happened, everybody actually came online and started asking things, because as I shared earlier, that it was not included in the emergency health services at first. The hospitals regarding family planning were closed at first during pandemic. So that proved the point somehow. And one of the reasons why we really want to keep working is the reason why people are approaching us and the success stories they have been telling us. Next, please. So concerns in implementation were that we made sure that we were culturally sensitive. We were not using any words that were, sort of harsh for people, because it's really, really sensitive. The capacity at state level is very low when it comes to digitalization and innovation practices. And inclusion of youth in the civil society and state level is something I would say there's a lot of tokenism approach. I want to be in those platforms where my voice would reach somewhere. I would not be following old practices or the mainstream things. I want to bring my ideas to the table. Rest, whatever happens is fine. So there are so many issues and resources we do not have in country fundings at all. Women-led initiatives already are looked down upon in that way that she's going to get married soon and she'll have kids. She is not going to be serious about the organization. So that is also one of the bias that I felt. And then afterwards, I feel like there's not enough funding in the country. Even if we were recognized by Punjab Population Innovation Fund, there was literally no help, which is like financial, and which caused a lot of struggle, because we all were young people. We really wanted to keep the momentum, and it was going, people were knowing about it, so it was very difficult to have some gaps because of the financial resources. Our currency has been devalued so much. There's like inflation across the globe, I agree, after pandemic. But when it comes to Pakistan, there has been a huge devaluation in the currency, and from the state departments, the fundings furthermore, the services are furthermore reduced. So these were the concerns we had. So that's pretty much about the idea. The future projections just in our mind, that we started from one city and we developed mobile application and we went for other iOS and web app. And in 2022, we are planning to have the countrywide dissemination, because we were limiting to the province, and now we want to go to other provinces as well. And then at this point, we do have provincial outreach at the community level, because we have trained young people again with the tool. And for the next 5 years almost, we want to have the national level clinics data and doctors on board, where they can ask questions even if they're offline or they're being sent to the email, who can respond to their queries, those methods which are specifically contraceptive methods, and people do not know the details about that. In this way, this one platform would be a free and full-fledged platform for family planning that anyone could recommend. Next. So thanks everyone. If you have any questions, I would love to answer. And if you want to reach me out, you can reach me out at biamashal@gmail.com. And you can also see my mobile application. Its name is Bridge the Gap. It's available online. The links are also on my website. So I hope it has been useful for some of the people, and thank you very much.
Wonderful. Thank you so much, Larry. That concludes the presentation portion of our webinar. And now we're going to move on to our questions and answers portion for about 10 minutes or so. So please, I ask everyone to put your questions in the questions section of this webinar platform. It looks like we have one first question. So it is from Temur Seyidov from Turkey. And he says, thank you for the presentations. In some low fertility context countries, such as Western Balkans, traditional method use is very high, more than 30% in Albania, for example, whereas modern methods are one of the world's lowest, 4% in Albania. Are there any studies explaining why people opt for more traditional method use? If this predisposition to traditional methods is by actual choice or conditioned on access issues, and also how negative social norms can affect choice, and also how BCC frameworks can help to dig deeper on this issue. Thank you. So I'll give that question to Lynn and Joanna.
Sure, let me try to answer. Thanks for the question. I think, yeah, I mean, the question itself, I think it's hard to know without knowing the research from that area. In some other contexts, though, I think the situation has been that traditional methods are what most people are aware of, and therefore kind of the default is to use them. So again, connecting back to this brief and the technical information that is captured in it from the literature, it could be that knowledge around modern methods is low. And again, looking at data from those countries, I think would be the first step, trying to really understand, where is the knowledge and what are the preferences? Are there social norms that are more supportive of traditional method use? Maybe there are access issues where people are not able to access modern methods at a facility, or maybe when they do get to the facility, they don't feel that they are supported in their choice. So I think it could be any number of those things, and apologies, I don't know that context as well, but certainly looking at the research to find out what the reality is on the ground in terms of knowledge attitudes, beliefs, and self-efficacy would be a starting point. And absolutely, social and behavior change interventions could address that. You know, once you kind of know what the foundation is. But maybe Joanna has something she'd like to add.
No, nothing to add, Lynn. You captured it well.
Okay, great. Thank you. As we receive more questions, I will ask a question, and this one is for clarification. Joanna, in one of your slides, you mentioned gender synchronized approaches. Can you say a little bit more about what those are and why they're important? Please, thanks.
Sure. So gender synchronized approaches means working with both men and women in a coordinated way. So sometimes we see programs that focus on male engagement, for example, that may try to reach men with knowledge and information, but are not reaching women with the same information. And similarly, we'll see family planning programs that are only reaching women, but are not reaching men with the same information. And what we see is some challenges there when that happens, that there's this kind of disconnect between the information that women are getting and men are getting around family planning. And sometimes that can cause kind of problems within the household. So we really believe, especially when thinking about some of the gender determinants of family planning and any SBC programs that are trying to address those, that it really works best to have this kind of dual approach where you're working with both men and with women rather than one alone.
Great, thank you. Great. Another question. This one is for Larry. And actually, let me go to a question from one of the audiences before I ask my question. So this one is from Jonathan Kunthorpe, and he says that the presentation was excellent. Thank you very much for the information. And meanwhile, there he has a theoretical question. He says he heard a lot about nudging. So nudging as a social and behavior change approach, in terms of moving people from A to B to practice a behavior. And is it connected to SBC or totally separate? And this could be for Larave or also from any of our other panelists. Thank you. So I don't know who wants to get started. Maybe we can start with Joanna and then see if Lynn and Larry want to provide some more information. So Joanna, can you please take this one? Thank you.
Sure, I can jump in. So nudging really stems from behavioral economics, which is one of those studies that influences social and behavior change. But it's really looking at these small actions that can kind of push someone towards a behavior. Perhaps they already had an intention around performing a behavior, but it's either a kind of a mental nudge. It could be around knowledge. It could be more of a physical nudge around sort of making the choices more easily available. It's really kind of stemming from this idea of giving someone a small piece of information or making something a little bit easier to choose a specific option, for example, around family planning. But it really stems from behavioral economics, which has some other these kind of mental mindsets in terms of moving towards social and behavior change. Perhaps others have something to add.
Great, thank you. Lynn or Larry, do you want to add anything else, or should we move to another question?
Nothing to add from me. Thank you, Maria.
Okay.
Yeah, we go to the next question.
Okay, wonderful. Let's go to the next question. This one is from a colleague from Pakistan, and he is noting that he's interested in understanding how the app that Larry shared can have a stronger outreach among the urban poor communities in Pakistan, noting that the awareness and access to app-based methodologies may not be as extensive as for some other groups of folks that have more resources. So over to Larry with any thoughts on how to make this technology accessible to the urban poor. Thank you.
Sure. First of all, thank you, Jonathan, for your comment as well. I hope your answer has been given. And for Kanupriya, thank you very much for the question. So this question has been asked to me a lot of times. And when it comes to rural areas, there are so many things that are already going on from our side as well as from the other organizations. For example, it's street theater, it's the training programs, it's outreach by the doctors and LHVs, and how we can also, sort of think about the quacks who are so much ingrained in the societies. But when it comes to the urban slums, as per our research, especially when it comes to social media like TikTok and YouTube's, majority of the people who are young, like the millennials and Gen Z, they are having access to the internet when it comes to the urban areas, but the poor conditions, I get it. But in our country, we still have access because the internet packages are very, very cheap and very easy to access. So if they have the services, they definitely have the internet. Internet is only not, sort of being used in those areas where there are no towers, where people have literally no choice. But wherever there are towers, people are accessing it. One thing is only which bothers a little bit is that the number of men are more. That's true when it comes to the poor communities. But what we do is that when it comes to those things like websites, people are having access to in the colleges or in the universities. We do access them through that portal. And if they're out of school, what we do is that we keep on training them and tell them that how they can utilize in future if they have it. But for them, we have a special sort of separate sessions which are specifically designed if they do not have access to internet. For example, IEC material, books, trainings, street theaters, theater programs, and showing them also the videos which are being downloaded already to make an impact. I hope I answered your question.
Great, thank you, Larry. Let's go to another question. So this question is from Anne Fiedler, and she's asking that for adolescents, even with high knowledge, positive attitudes, available services, I think ability to act is key, yet it is sometimes lacking. How has this been addressed in different settings? And maybe, we can add to her question, what are some SBC approaches that could be used to help address this challenge that adolescents face? Thank you. And maybe we can go to Lynn or Joanna to answer this one.
Joanna, do you want to start?
You go for it, Lynn.
Okay. Yeah, I mean, it's a great question, and I think there is, a lot of evidence and so many initiatives that have been focusing specifically on adolescents and young women. I think one of the keys is really looking at the socioecological framework that, in some cases the issues may be around knowledge, attitudes, but this issue of self-efficacy related to access, which is related to how one is treated, an adolescent perhaps is treated when they arrive at a health facility to access a method. All of those things, play a role in whether that young woman is able to act on her reproductive intentions, whether she is able to access and use a contraceptive method and practice it effectively. Then we mentioned earlier the issue of side effects and, knowing what to expect when you do start a method. All of those things are tied in. So I think, again, we don't have a ton of time, but there is a great deal of information around adolescent sexual and reproductive health and social and behavior change programs that have addressed their needs. So I really refer you, just given lack of time, to the Compass for SBC, to the SBC database that Joanna mentioned, and all of those resources have been shared in the chat, and certainly I invite you to return to them after the webinar is posted. But there's a great deal of information out there now, and I realize we're at time, so I'll stop speaking.
Great, thank you so much, Lynn. And yes, we are at time, so I'm going to have to close the webinar. But before we close, I want to share the hyperlink with the presentation and recording. The webinar will be posted in that link very soon. Please stay tuned for that. And for more information on the new SBC briefs and to get a copy of the other briefs presented today, please go to the HIPS website noted in the next slide. And thanks again to all the panelists for being here with us today and sharing their experience and expertise. Ados May from the IBP Network who organized this webinar today, and to all of you for participating and attending to this webinar. Have a good rest of your days. Thanks. Bye.